Chapter 25, Prostate Cancer and Genetics. This is a genetic test for men who want to know about the prostate cancer risk as well as prostate hyperplasia, which is basically an enlargement of the prostate. It's not actually a cancer yet. Now, prostate cancer and prostate hyperplasia are influenced by 10 different genetic variations. And each one of these genetic variations can either increase the risk or not increase the risk. And by looking at all of these together, we can create a risk profile of a person. And these are the genetic variations that we test. As you might have seen in other trainings, this here is the gene name. This here is kind of like the catalog number of the genetic variation that we analyze. So this is a unique identifier for the genetic variation. And this is the genetic letter change. So normally this gene at this genetic variation location has a G, and it is changed to an A. And this here is just a small cutout from the report. If you look at each of these genes in detail, and you can actually find this text here, or this table exactly like this in the report itself, so you can have an insight into the science behind it. First, you see TCF2, that's the short name for transcription factor 2, and this is, as I said, the catalog number. A short explanation of what this gene does. And then there are three different possibilities. So AA genotype means that both genes, every person has 2 copies of every gene, with some exceptions, but in this case it's AA on both, so both genes have an A, or it could be both genes have a G at this location, or one has an A and one has a G. So these are the 3 possible results. In case you want to know more about this, do check out the training for simple disease risk statistics. All right, this person here with the X has a GG genotype. 26% of the population has the same genotype, so about a third of the population has the same. And in this case, the meaning is no increased risk for prostate cancer. And if you have an A and a G, which is more than half of the population, also no increased risk. And if the person had an AA, it would mean that the risk is odds ratio 1.4. If you don't know what odds ratio means, I would also recommend the disease risk statistics training. There you'll learn everything about it. So the risk is 1.4 that of a person with the optimal genes. Here are the scientific references for it. So this is just one of the 10 genes. If we look at the next one, again, there are different genetic letters that could be present. 19% have an increased risk of prostate cancer. It's a 1.28-fold risk, so 28% higher risk. And the references here show the different genetic papers that have looked at this genetic variation and found this association with increased risk. Looking at the next gene, that's actually not a gene, it's AQ24, means on chromosome 8 at location 24. It's usually not really genes in this position, but it's some important genetic code. And in this genetic code, there is a genetic variation and has been found to influence the risk. And as you see, 5% have an AC genotype, a 1.53 risk, so 50% higher risk. And 1% have an AA genotype, also have a 53% higher risk. The next gene, that's the vitamin D receptor. The body produces vitamin D when you are exposed to sunlight. And the vitamin D receptor is necessary to recognize this vitamin D, to let it establish its function. So 56% have 2 Cs in the vitamin D receptor gene and have no increased risk. 36% have a 1.11-fold risk, so 11% higher. And actually 8% have a very high risk, a 2.5, almost 2.5 times risk. So having a genetic variation in this receptor reduces the effect of vitamin D, and vitamin D deficiency is a critical risk factor for the development of cancer. All right, so these were just some examples. If you're interested, check out the report. There you can find this detailed information for every one of these 10 genes. And here you can see a summary. The optimal genetic profile, meaning that all 10 genes have the optimal genetic version of the genetic variation. Compared to the worst genetic profile, this has a relative risk of 1, and the highest risk has and a relative risk of 359. So if we draw a line from low with an odds ratio of 1 to 359, any person will be anywhere in between here. And these genetic variations are not uncommon. So if you look at the general population, you will find that almost everyone has at least some of these genetic risks. Some people have more than the average and other people have less than the average, which means some people have a higher risk than the general population and other people actually have a protection. So the average risk, we know from studies, is an odds ratio of 6. So if you have an odds ratio of 6, you have the same risk as the general population. If it's higher, you have a higher risk, or lower, you actually have a protective effect. All right, and as I said, we have 3 functions: prevention, early detection, and better treatment for prostate cancer. So looking at the prevention side, there are a number of risk factors in your lifestyle or in a person's lifestyle that can increase the risk, and that should be avoided, especially if the genetic risk is high. So one of the prevention advice things that we would have in the prevention program is avoid high calories and high fat intake or animal products. Then you should practice regular exercise. This all reduces the risk of prostate cancer. Avoid alcohol as a risk factor. Follow a diet rich in vitamin D. Vitamin D can be produced, as I said, through sunlight on your skin, so do some outdoor activities, but vitamin D can also be taken in through the diet, especially in sea fish. It is quite common. So if you follow this preventive advice, and it's explained in much more detail than I've just shown here, then you can reduce other risk factors that would also increase your risk and thereby work against your increased genetic risk. The next part is early detection, and this goes for all cancers. If it's detected very early on, it's usually very well treatable. If it's detected too late, it has already metastasized, which means that the cancer has spread and has started to invade other tissues. So early detection is critically important. And so what people should do for early detection, especially if the risk is particularly high, they should go to more frequent, earlier and more thorough prostate examinations to find out if prostate cancer is developing. So there are a number of ways a doctor can check this up, and one of them is the PSA measurement in blood, and there are some other ways of keeping an eye on the prostate. And you should also be aware of the symptoms of prostate enlargement so that you can detect it early and get immediate treatment. So not that it takes years for you to finally go to a urologist to look at the problems, but you should be aware of the symptoms. And if any of these symptoms show that there might be the onset of prostate cancer, you can get immediate treatment, and as I said, that is usually very effective. So we do our best to prevent it. We then make sure, especially in high-risk cases, that we find it early if it ever develops. Obviously, the aim is not to let it develop, but if it does, we can detect it early. And then we have improved treatment. There is a training on the pharmacogenetics part, so how drugs are metabolized, how they work, and how they might not work or cause side effects. We have certain genes, and these genes break down a certain drug. So one drug, which might be a chemotherapy drug, is metabolized by one gene. And if this gene is deactivated by some genetic variations, then the chemotherapy drug might not work, or it might cause very severe side effects. So what we can do is we test these number of genes, and then we can look at anti-cancer drugs, anything to do with cancer, not just chemotherapy, but all surrounding drugs as well. And then we can see how fast they're broken down. And you will see this kind of table. These are the different substances. This is the effect. So this drug will have normal effect. Some people have a lightly higher effect because their drugs might be activated more quickly. Then the breakdown is different. So for some people it's 100%, or for some drugs, some it's 95%. Some people have more common adverse reactions which should be avoided, and the recommended dose might also differ. And if an alternative is recommended, if the drug really is not broken down at all, then you would see here that there's an alternative drug would be advisable. And that's the end of chapter 25, prostate cancer and genetics.